So it's time to start with our first presentation. Our first presenter is Professor Mark Peterson. He works at the University of Michigan in the United States, and his research focuses on physical medicine and rehabilitation. He has an interest in factors that influence access to preventive care, healthcare needs, life expectancy, as well as understanding health disparities among individuals with physical disabilities. He is very well known for his research focusing on health aspects and aging in people with cerebral palsy. And I have had the privilege of listening to Professor Peterson's presentations a few times, and I can assure you that they are always inspiring and thought-provoking. So I'm happy to welcome you, Professor Peterson, to this webinar, even if you had to wake up almost in the middle of the night, well, very early in the morning at least, and looking forward to your presentation.
Yeah, thank you very much.
The floor is yours.
Can you hear me okay?
Yes, we hear you very well.
Okay, well, thank you very much for the kind invitation to present, and I'll try to share my screen now again so we can.
Yeah.
Here we go. Okay. And hopefully you can see this.
Yes, we see it very well. Thank you.
Great. Thank you very much. So again, I'm Mark Peterson. I'm on faculty at the University of Michigan in Ann Arbor, Michigan. It's 7 o'clock in the morning here. So I'm at the gym because that's a good place for me to take a meeting instead of my house where I have kids getting ready for school. So the title of my work is Cerebral Palsy Grows Up. And I title a few of these lectures like this because it's an indication of kind of two things. One is that CP is a lifelong disability, and historically it's been very largely focused on pediatric care. And so a lot of the work that's being done now out of my lab and my department is pertaining to lifespan. And so it's important that we talk about what happens with age. The other thing is that the state of the literature has grown significantly over the years. And so cerebral palsy grows up represents two things. It's lifespan condition as well as the state of the literature, and the number of publications and experts around the world doing work has grown as well. So with that said, I'll see if I can change my slides. There you go. I have no disclosures. This is my institution. This is the law quad on the left and the medical school on the right. A lot of the time that I spend is in this football field. This is where our last year's national championship football team plays their home games on Saturdays. So I will actually be there this Saturday. So I don't think I need to introduce what cerebral palsy is, but I will anyways. It's the most common pediatric onset physical disability. The estimated prevalence range somewhere around 3 per 1,000 live births in the United States, as well as globally. It is caused by a malformation or insult to the developing brain, which affects motor control centers and causes alterations in growth, development, and overall health. But many individuals with CP, as I said earlier, can expect normal life expectancies. And yet there's a lack of clinical follow-up and care coordination for patients once they transition from pediatric to adult. But I've actually noticed that in some parts of the world, and perhaps Finland, but also the rest of Scandinavia, there is better infrastructure for care once transition takes place from pediatric to adulthood. But in the United States, there's really what we consider to be a healthcare cliff that folks fall off once they become adults. And so, again, the focus of my work has been really largely to understand lifespan healthcare needs, as well as reducing healthcare disparities after transition. So we all know that with age, comes risk for, just in the general, normal, typically developed population, risk for frailty, physical dysfunction, disability, further mobility disability, chronic disease risk, cardiovascular mortality, and all-cause mortality, all increase with age. So again, sort of the focus of my work has been to try to understand the natural history of CP across the lifespan, especially from the context of how aging and risk for chronic disease increases with age in early midlife and then later adult life for folks with CP. So it's not just a factor of age and frailty. As we all know, there is stunted growth, diminished skeletal muscle mass, bone density, even in children. My colleague, Dan Whitney, who has recently left our institution, did a study during his doctoral work, which showed that even in ambulatory children with CP, they have much greater deposition of fat in the muscle, around the muscle, as well as inside the bone marrow space. So this is thought to be one of the contributing factors or mechanisms for early frailty in this population. So my question has always been, what happens to children, adolescents, and young people with CP as they transition through adulthood? In the United States, anyways, there's now more adults with CP than there are children. And so we need to reframe what cerebral palsy is to move from a pediatric-centric definition to more of a lifespan. And I've even talked with our US CDC about redefining what CP is, because they still have as a definition, it's a pediatric physical disability. So some of the contemporary jargon that's used amongst our clinical colleagues are, we see accelerated aging, we see premature frailty, there is risk for normal weight obesity, which is basically exactly what it sounds like. Somebody has normal weight and yet they have high adiposity stores. And then highly sedentary behaviors, a lot of time spent in sedentariness. Some of the first papers that I published on this go back before I was even on faculty. I wrote some concept papers, which ended up being the foundation upon which I built my career, frankly, about, and these are reviews about the lack of literature pertaining to lifespan. When I was hired as a postdoc and then on faculty back in 2008 and 9, there was literally zero studies published on health outcomes and health disparities for individuals with CP across the lifespan. There were concept papers, but there were literally no studies published on the risk for chronic disease in this population. So one of the first papers that we studied, one of the first studies that we completed, was simply to look at differences in body composition amongst individuals with CP, adults versus those without. And what we found was that adults with CP who were matched on the basis of gender, sex, body mass, and age had significantly higher adiposity stores. We determined these using computer tomography scans at the L4 level of the vertebral column. And so you can see on the right, this is an individual with CP, and then on the left, a matched individual without CP, not obese by any stretch of the imagination, but the individual with cerebral palsy has significantly greater adipose stores in the subcutaneous depot as well as the visceral depot. And in addition to that, we found that they had much lower bone densities in the vertebral column, as well as low density of the psoas muscle and the erector spinae muscles, indicating that there is lipid in the muscle as well. So this was our sort of first foray into trying to understand the differences. And again, this shows also that using a body mass index, BMI, to capture risk for obesity is probably not appropriate for this population because it's a one compartment model and doesn't take into consideration body composition in any way. So this individual had roughly 50% body fat by DEXA by comparison to the individual without CP. So given what we know about sedentariness and increased risk for adipose tissue, the next question that I had was, do individuals with CP have risk for chronic disease? I mean, we know that obesity or high fat stores are predictive of negative health outcomes. And so we started to ask that question: is this is a potentially a preventive cause of chronic disease? And if so, how do we know? At the time, there were literally no cohort studies out there that we could leverage in there. We have a large adult clinic, but at the same time, there were no large cohorts that we could leverage to look at this. So I collaborated with a health economist here in the United States to look at a large survey of basically a population representative sample of U.S. adults, and we looked at just normal chronic diseases and showed that basically for folks with a diagnosis of cerebral palsy and without knowing anything else about them besides some of their sociodemographic information, do they have increased risk for chronic disease? And so we looked at various organ systems, and across every organ system, we found that there were higher risk for chronic disease than for folks who do not have CP. So the blue bars indicate adults with cerebral palsy, and the yellow is folks without cerebral palsy. And so you see diabetes, asthma, hypertension, other heart problems, stroke, emphysema, and probably the least surprising is joint pain and arthritis were higher in CP. Then I got a little clever and I started to use, we have totally different type of healthcare system than you guys have, but we have privately insured individuals and federally insured individuals. So I was able to leverage and gain access to a large privately insured network of administrative claims data. And we looked at longitudinal trends in cardiometabolic diseases in adults with CP, which we published a number of years ago in Developmental Medicine. And basically what we found was that the cumulative incidence for each of the cardiometabolic diseases ranged from 6 to 34%, and that's in only 3 years of enrollment. And there was no control group for this. It's kind of a basic study design, I might point out, but we were able to look at longitudinal incidence. So, do they develop these diseases in a short amount of time? And so you can see for diabetes, almost 12% incidence, 34% for high cholesterol, 30% for hypertension, 13% for cardiac dysrhythmia, and 6% for atherosclerosis. And to note, even though there was no control group, the 3+ year cumulative incidence for hypercholesterolemia and hypertension are similar to the lifetime risk of these outcomes in an otherwise healthy non-CP population. So I think that's it's starting to look like there is potentially an issue in terms of the metabolic demand and cardiovascular risk in this population. So those are two of the leading causes of early mortality in the United States. And so that's of note, that's really important to consider in the context of preventive screening and healthcare provision for this population. So we know that term early aging is thrown around a lot, and I think it's probably being used haphazardly, but it is reflective of a clinical notion that there may be risk for a premature aging phenotype in this population. So, but just using it inadvertently is not something that I really like to do. So instead, we wanted to look at, is there increased risk of morbidity and multimorbidity in young adults with CP? Because if indeed early aging is a real thing, then there would be evidence of morbidity and multimorbidity in younger adults with CP than the general population. So again, we have a large clinic at the University of Michigan, which we leveraged, and we're able to look at adults with CP who are between the ages of 18 and 30, as compared to adults without CP at the same age range. And what we found was, lo and behold, that adults with CP, you can see on the x-axis, there's this morbidity score. So 0 being healthy, no morbidity, 1 having 1 across every organ system. We basically included, outcomes that are relative to chronic disease. 2 would be multimorbidity, 3 and 4 is extreme multimorbidity. And what we found was that young adults with CP had pretty high risk for developing lower risk of being healthy, higher risk of having either one or more comorbid outcomes. And again, to underscore, these are 18 to 30-year-olds, so they should not have diagnosis of osteoporosis and cardiovascular disease and diabetes, but that's exactly what we found. So is that truly a signature of early aging? I don't know if I could go so far as to say that that's not a mechanism of study, but we are finding evidence of chronic disease that are considered historically to be related to age, and especially advanced age, midlife, and older adulthood. So again, there's some evidence here to suggest that adults with CP are at risk for an early aging phenotype. Since these original studies, we have basically checked the boxes across all organ systems and have been really trying to look at, across cohorts, and have looked at, we've probably published, I don't know, close to 50 studies at this point to try to understand healthcare, risk, health needs, disparities facing healthcare access, and really have done a lot of work in the space of what we're now saying is preventive healthcare for adults with CP. I want to point out that a lot of times when I give these lectures, that inevitably somebody will tell me that this is really bad news and it's scary, and I don't disagree. I have a young son with cerebral palsy, so some of this stuff is very personal to me as well. But I also really try to point out that by pointing a spotlight and highlighting these needs and healthcare disparities, that we can maybe start to understand ways to prevent these things. And sort of the triad at this point of preventive care is good sleep hygiene, healthy dietary habits, and regular physical activity and exercise. And so a number of years ago, a good colleague of mine, Olaf Schuren, and other colleagues wrote up some physical activity recommendations for people with CP. And we were specifically interested not just in adults, but across the lifespan for kids and adults. And what we found was that we made some recommendations, but in a small meta-analysis that we were able to pull into this review, is that we found that using actigraphy, synthesizing the data from some good actigraphy data, we were able to look at sedentary behavior, light physical activity, and moderate to vigorous physical activity. And the different colored bars represent GMFCS levels, so GMFCS 1 through 5. And as you can see, sedentary behavior, the y-axis is percent of 24 hours. Sedentary behavior represents the largest component of activity. And then light physical activity is quite a bit lower, and moderate to vigorous is only represented in GMFCS 1s, 2s, and 3s. So I think if we were to start to try to tackle some of the issues pertaining to chronic disease prevention, we should be really trying to look at reducing this. All right. I am a maximalist by training. I'm an exercise physiologist as by training in my undergrad. And I would love to see these increase as well. But I think if we can reduce this and increase light physical activity, we may be able to have a pretty large effect on the population who consumes such high sedentary behaviors. Again, there's a big difference between sedentary physiology and exercise physiology, but I really believe that tackling the reduction of sedentary behaviors can really lead to large changes that may end up contributing towards adoption of physical activity to improve exercise physiology. I love this quote. Robert Butler, former director of the National Institutes of Aging, says, "If exercise could be packed in a pill, it would be the single most widely prescribed and beneficial medicine in the nation." He wasn't referring, obviously, to folks with cerebral palsy, but the United States leads pretty much every category in chronic disease and obesity. So he was referring to just general health in the general population. I like this picture because it almost shows an evolution of what man has come from and now sits in front of a computer like I'm doing right now, and I do every day, writing grants. But it is important that we start to educate the population about physical activity and reduction of sedentariness. I don't need to talk about this. This is a real picture from Los Angeles where folks are taking the escalator to go to a fitness center instead of the staircase. And I find the irony in this hilarious because it is a real picture, and that is truly the reason why we've packaged exercise incorrectly here, especially in the United States. I feel like every time I go to anywhere in Scandinavia, I'm always impressed by the number of people walking and biking and kayaking and being physically active. But in the United States, it's been packaged the wrong way. And I point this picture out because it always makes me chuckle. We, along with some really good colleagues in Canada, Jan Willem Porter and Patrick McPhee, put together a core outcome set for multimorbidity risk in individuals with CP. I think it's important that we start to look at not just the outcomes, but the risk factors associated with the outcomes so that we know where to intervene. And maybe some of you know, but I'm working with Cerebral Palsy Foundation right now and a group of international colleagues to put together the first ever clinical practice guideline for CP, and we are actively working on finishing that. So look forward to that coming down the pipeline as well. Let's see, how much time do I have left? Oh, I got time. Some of the questions that we've been asked more recently, and I gave the Chamber's Lifespan lecture last year at AACPDM. Hank Chambers is one of the first people that kind of said there may be risk for mental health disorders in our population because his personal experience with his son, as well as patients that he'd seen in clinic, are starting to say, you know, we're having risk for depression, anxiety, and other mental health disorders. And since then, we started to look at that as well. And I think that I'll take the rest of my time to talk a little bit about some of our recent work about mental health and pain. So Jen Ryan, a really good friend of mine and colleague, and Kim Smith, both in the UK, and I did a study a number of years ago. It was the first study kind of ever published on this, looking at the risk of depression, anxiety in adults with CP. And we published this in JAMA Neurology and looked at 1,700 adults with CP in the UK and just over 5,000 adults matched without CP. We wanted to look at the incidence of depression, anxiety in adults with CP by comparison to adults without CP. We found was that for folks with CP, there was a fairly increased risk for both depression, anxiety, both prevalence and incidence. And then a sort of a secondary finding or sensitivity analysis, we found that people with CP who had no comorbid intellectual disability had a higher risk of incident depression, anxiety than individuals with CP that did not, that did have comorbid intellectual disability. We wanted to follow up and replicate the study using a much larger set of a cohort of adults with CP here in the US, and published this a few years ago, and looked at 37. So we extended that work looking at just depression, anxiety, and we extended to 37 mental health disorders in a large cohort of 7,000, just over 7,000 adults with CP versus a much larger 8.7 million adults without CP, adjusting for sociodemographic and neurodevelopmental comorbid conditions. And we found across all categories, basically, that there was much higher risk, both in women and men with CP, much higher risk than without CP for developing these mental health disorders. And interesting difference from the study in the UK, we found that folks with CP and co-occurring neurodevelopmental conditions were at increased risk than for folks with CP alone. And that was virtually for every single outcome. So a little different in the United States. Neurodevelopmental conditions would represent autism spectrum disorders, epilepsy, and just intellectual impairment. This is not so recent anymore, but I get emails like this literally all the time. I came across your journal article on the prevalence of mental health disorders in adults with CP. I'm a nurse working in clinical research. I have a 45-year-old cousin with CP. She only very recently started exhibiting severe anxiety and depression. I suspect bipolar. I'm looking to find a clinician specializing in adult CP, mood disorders, etc. As you can imagine, and I don't know how different it is for you, there are very few providers who are both experts in adults CP care and also mental health. behavioral and mental health provision. So this kind of an email is a difficult one to answer, except with some sensitivity, because there are very, very, very few points in the right direction I can provide for somebody like this. We extended this work to look at a much larger cohort of adults with CP and spina bifida. Spina bifida is definitely different than CP, but their clinical presentation, especially in adulthood, are very similar in many ways. And so we collapsed a cohort of these two conditions into one and looked at just about 15,000 adults with CP or spina bifida and used an incidence or a longitudinal modeling approach to look at hazard ratios amongst common psychological morbidity at 4 years of enrollment. And after adjusting for virtually everything you can adjust for in a model, we found that every single outcome besides alcohol-related disorders were highly elevated in adults with CP and spina bifida in terms of a hazard. So again, not to really kind of continue bolstering this, but it is something that I do think that we should be focusing on, and not just the detection, but also maybe the prevention. And it's certainly something that I started to think about talking to pediatric colleagues, because, psychological outcomes like this don't arise just in adulthood. I think they potentially have some origins in children. So what about pain? I think pain, you can't almost talk about CP without addressing, I don't know if the term is relevant to other populations, but the elephant in the room. Pain is a really, really large component of cerebral palsy. So given that pain is highly associated with chronic disease, including musculoskeletal disorders, and is chronic pain a causally linked to psychological morbidity in CP is a question. What is the phenotype of chronic pain in adults with CP? And what is the national prescribing pattern for opioids? I don't know to what extent opioid issues are relevant to this audience, but it is really relevant to colleagues here in the United States and people with CP here. So I'll take a few more minutes and then I'll wrap up. We did a study looking at the effect of pain on mood affective disorders in adults with CP. And what we found was that adults with CP who had new pain or consistent pain had greater crude incident rates of mood affective disorders compared to adults without pain. I would posit that most adults with CP have pain at some point in their life, but we were able to isolate pain diagnoses on the basis of ICD-9 and 10 codes in administrative claims data. So the elevated rate of mood affective disorders remained even after adjusting for covariates of new pain and consistent pain. So I do think that if we start to think about mental health, we also are obligated to consider pain and pain experience. It's not, so pain is a widely studied phenomenon, but pain in CP has been really reduced to peripheral pain. So pain that arises from what we say nociceptive mechanisms, or pain that originates from physical damage or overuse injuries. And that has been the primary focus in cerebral palsy. It has been really reduced to that. But we know that folks with CP can have neuropathic pain as well. So pain caused by damaged or disease affecting somatosensory nervous system. And then most recently, a centralized pain, nociplastic pain, has been designated by IASP task force as what used to be considered a fibromyalgia, but now is considered to be more of a chronic overlapping pain condition, or nociplastic pain. So that's a newer designation that has really yet to be explored in CP. And we really wanted to try to get to the bottom of is what are the pain phenotypes among adults with CP? And I included spina bifida as a cohort as well. And what we found was that adults with CP or spina bifida had a higher prevalence of any pain disorders and pain multimorbidity as compared to adults without CP, and differences were to a clinically meaningful extent. You can say, I don't need to probably say, but the prevalence was significant across all phenotypes: nociceptive, nociplastic, neuropathic, as well as the adjusted Logit models for each of them as well, after adjusting for very lots and lots of different sociodemographic variables. So then we wanted to look at a deeper dive here at Michigan in a clinical cohort of adults with CP, a much smaller cohort of 71 adults with CP who presented at the University of Michigan. And what we found was that, again, I say that it's important to recognize that peripheral mechanisms of pain are certainly an issue in this population. But we found in terms of a phenotype that 39% had only nociceptive pain. So that's 40%. So the vast majority had mixed phenotype, which means that they many had nociplastic pain. So 34%. So almost the same size piece of the pie as a nociceptive mechanism. We're finding a centralized mechanism of pain, but then also evidence of neuropathic alone and neuropathic plus nociplastic pain. So it's important to use the right screening tools, which if anybody's interested, I can provide our screening tools that we use to identify the phenotype of pain so that we can treat the pain the most appropriate way. We also found that scoring positive for nociplastic pain predicted significantly worse self-reported depression and perceived stress above and beyond the effects of pain and intensity. So pain is highly variable in adults with CP, and it may arise through multiple mechanisms, including central mechanisms. Again, opioids are a problem in the United States. They're a very blunt instrument for treating pain in a perioperative sense, but they're effective. And so that's why they're used after surgery. And certainly folks with CP have surgeries. But we are interested in trying to understand about what extent of non-perioperative opioid prescriptions are taking place. And we looked at, if they had them, if they were they had pain diagnoses, if they had a single isolated pain diagnosis, or if they had chronic overlapping pain. So again, a large cohort of adults with CP or spina bifida, we found that folks with CP in most cases had double or triple the oral morphine equivalents prescribed to them as adults without CP or spina bifida. And again, it's important to point out that these were for non-perioperative prescriptions. So again, pain, mental health, and then you throw opioids into the mix. I think we're really doing a disservice to the population without better understanding. And for the non-pain folks in the room, using opioids to treat neuropathic and nociplastic mechanisms of pain actually can make the pain condition worse, and clearly can lead to addiction and mental health disorders. And not to mention respiratory distress, respiratory failure, falls, fractures, and a lot of other things. So it's a problem, especially in the United States. And you can see the trends in terms of oral morphine equivalents across time. Okay, so I'm going to wrap up here. Wondering, I published a study just last month in JAMA Neurology looking at a much larger cohort, but I didn't feel like I needed to put this in here. But I'm happy to send it to anybody that wants to look at pain or consider pain. Really interested in sleep, cognitive behavior therapy, exercise, as first line treatments for this population. I also think we need to do better in preventive screening. That's something that is usually not done in physical medicine and rehab, but I'm trying to convince my clinical colleagues that they need to be doing more preventive screening. And actually that should go across kind of all organ systems and cancer as well. Reduce healthcare disparities across the lifespan by improving care coordination, continuity through the transition phase. And then, as I said, I'm in the process of developing clinical practice guidelines in collaboration with the CP Foundation. I like to update this every time I give a lecture. So you can see, as I said early on, cerebral palsy grows up is not just about people growing older, but the landscape of publications pertaining to anything related to adults with CP. This is not healthcare. These are usually these early studies were, on vocational needs and caregiver needs and caregiver burden. But as time has gone on, the landscape of literature has really changed. And actually over the last 10 years is representative of over 80% of all publications. So it's a new field. It's really, I'm proud of this because, we started doing work, just over 10 years ago. But I also am extremely proud of all of my international colleagues that have contributed to make this happen. Last thing I will point out is that we haven't published this. It's in review right now, developmental medicine, but we looked at the amount of money funding from the National Institutes of Health across CP as a condition, and then broke it out into the type of study that had been funded on. And this very small green line down here represents lifespan issues. So you can see across 2014 to 2021, and we've updated it to 2023. So this graph is old. Less than 2% usually of the funding portfolio at the NIH is dedicated to adult or lifespan related issues. So I've been relentlessly advocating in Washington, D.C. to try to improve this, and really have been, approaching a lot of politicians about the need for increased lifespan issues. I want to thank my colleagues, clinical and research colleagues, as well as a lot of other people. I always feel like I am standing on the shoulder of giants, as well as my funding from the federal sources of funding and my foundation funding as well. So I mentioned my son, Marcus. Here he is. He does adaptive horseback riding. We like to go kayaking. This is him biking. He has an adaptive biking program. And he jumps on the trampoline a lot, loves swimming. And I even had him playing ice hockey for a little while until it got too hard to put his gear on. So he's my personal motivation to continue doing this work. And I thank you very much. I think I can stop sharing now. Thank you very much.
Thank you really, really much, Professor Peterson, for a really, well, not only inspiring and interesting presentation, also a very important presentation, the great work you and your team is doing. Our next presenter is Dr. Pedro Valadão. He works as a researcher at Jyväskylä University here in Finland. He's a physical educator specialized in strength training and has a master in motor control. His PhD focused on implementing a training intervention for people with CP with the aim to increase motor function for everyday activities. Today, his presentation will be about effectiveness and safety of strength training. Pleased to have you here, and the floor is yours.
Hello, everybody. It's a pleasure to be here. Thank you for having me. Let me share my screen. So can you see it well? Oh.
We can see it very well. Thank you very much.
Okay. So as already said, my project was about an exercise program for individuals with cerebral palsy. As a physical educator, I have always been very focused on biomechanics and on strength training. And it was a very nice idea from a researcher called Jens Nielsen to use this knowledge in CP. So that's how the project started. It started in 2017, but we collected such a huge amount of data that we're still to this date trying to publish everything. And today I would like to focus on presenting to you the more practical aspects that can be used by anybody with any family or any individual with cerebral palsy. So Mark already made, I have a marker that I don't want. Okay, so Mark already made a very good introduction, so I won't take too long on this. But as you all know, although the main lesion that causes cerebral palsy is deemed non-progressive or static, there is a host of other secondary symptoms which are they progress, as Mark showed in his presentation. Although I don't really like the term static for the main lesion in the brain, because we know that the brain is constantly adapting and things are changing in the nervous system, right? But here we are going to focus on some secondary symptoms. So muscle weakness, so the inability to exert torque in the joints, incoordination. Mainly when I say incoordination, I'm talking about the lack of selective activation of muscles. So it's very common in CP that when you're trying to do a certain motor action, the muscles that needed to be activated are activated, but the antagonist muscles, so the opposite muscles, are also being activated. So that causes incoordination, and the movement gets it's not subtle, and it makes the agonist muscles, or the muscles that are supposed to be working, to have to exert much more strength. So the effort is much higher, and that goes into the subject of fatigue as well. And the third, and perhaps the most debilitating aspect, is the reduced joint flexibility. So we know that the range of motion problem in CP is a really big problem. We have loss of range of motion. So that's the ability of the joint to make a full excursion. And we have this problem of contractures, right? So for example, it's very common in the ankle joint to permanently lose movement. And then, of course, it affects everything, every type of motor function. So this mix of secondary symptoms, they cause lower physical activity, and they worsen the cardiometabolic health of the participant, of the individual. And this is a downward spiral, right? So you have the secondary effects that cause lower physical activity, which exacerbates the secondary symptoms. So it gets worsened all the time. So the idea of the intervention is obviously to stop this downward spiral and maintain or enhance the level of motor function for the individual. So when thinking about the types of intervention, I would like to give you a quick view of some different types of intervention and how they are being used right now. As Mark showed, there has been a lot more research in cerebral palsy, but we still lack some key information to perfectly choose the intervention type. So strength training is one of the most researched types of intervention. It has been shown to effectively increase muscle strength in individuals with spastic cerebral palsy, mainly if the established training guidelines are followed. So the training guidelines for strength training are like when the doctor prescribes you a medicine, so you have to take this amount of pills in this amount of days. It has some study behind, right? It shows how that it has a specific mechanism for that drug that has to be followed, and people understand that very well. But in exercise training, people don't think about that. So we already know what types of training loads are adequate to cause changes in the neuromuscular system. And sometimes some studies are using some very low training loads that don't get to this level that we consider optimum. And of course, in these studies, strength training are worthless because no changes happen. But if you search for all the studies that use the good training load, they found increases in strength training. That is quite consolidated. But then we have a problem with motor function. Some studies have increased in muscle strength, so the person got stronger, but nothing changed in the more functional tests. So for example, walking or climbing stairs, squatting, some studies show no change, right? So there's a conflict in the literature. And I think that most of all, what happens is that even if the study used a correct training load, what happens sometimes is that the study focused too much on one muscle group. So you can get a specific muscle group, for example, your tight muscles, to get stronger. but that will not necessarily change the function of your whole body. So trying to change walking by changing the strength of one single muscle is wishful thinking. It's not enough. And of course, we have other problems, as I discussed in the past slide. The person can even be stronger, but we have the incoordination problem, and we also have the restricted range of motion problem. So it's more than that. It's not just increasing the strength. So I think that's the main reason why some studies have not shown increases in strength. So the idea here is that increasing strength in the correct muscles that are used for the daily motor functions in a very naturalistic way. So the more you get away from very specific movements in the gym, the better in that sense. But of course, the paper that Mark showed from Olaf Verschuren in 2016 shows this very well. And I think this is important to discuss, that if you have some very specialized movements that are, we call them monoarticular, so they're like a movement that is restricted to just one joint. In CP, they're very good because you can control the movement very well. But of course, the movement is a motor action that has to do with, for example, walking, has to do with many different joints. So it has a small transfer from what you're doing in the exercise setting to what you really want to accomplish. But in the other hand, we have more complex movements like the multi-joint movements. So for example, squatting. They are very good because they are very natural and they are very close to what you actually want to do in practice. But because there are so many joints involved, the movement is much more complex, and there is room for mistakes in the execution that can cause pain and other problems. So you have in a spectrum between restricted movements that are very easy to control, but they are not very good to transfer. And in the other side of the spectrum, you have very naturalistic multi-joint exercises that are very good for transfer, but they are not that easy to execute. So we have to handle both of those sides. Another type of training, perhaps the most utilized one, is the flexibility training, mostly done in the passive static stretching. So usually a physician or a parent is just holding the muscle in a stretch position for a long period of time. And although this method is very much used, the efficacy is very unclear in the studies. And the main reason for that is that the studies are very short. So we have studies maximum of 3 months. And obviously we need more time to see how the muscles are actually going to change with longer term. And unfortunately, to this date, we don't have these studies. And another problem is the reliability of the methods to access flexibility. So it's not that easy to measure well. And the individual with CP can have different measures from day to day, just based on spasticity or if he's too excited or not. So there are some concerns in that area as well. But the biggest problem is that we want to understand if stretching is causing structural changes, or the changes are only made by tolerance to stretch. So there's a few studies showing that individuals got more flexible, so their joints could go to a wider range of motion, only because they were able to tolerate more the stretch, right? So they were used to this type of exercise, so they could handle it better. That's not what we want. We really want the CP muscle to adapt and get longer, because that would prevent the contractures, which is probably the worst problem in CP. But still to this date, we don't have enough information on this, mainly because it is very hard to measure structural changes in the muscle in vivo. So in a living person to measure this, it's very hard. So we still have very few information about that. But if we leave research and we go to the practical field, so clinical work and sports training, what we see in these two fields is that stretching works. So I have been working with Olympic athletes for 2 Olympic cycles in many years. And I can tell you that the amount of flexibility that the athletes gain after stretching for a long period of time cannot be just tolerance to stretch. The muscles are obviously longer. And also we have some contact with very good clinicians that have been working with CP for over 30 years, like Jean-Michel Gracies from France. And he tells me that in practice, what he sees in the clinic is that individuals that stretch a lot are able to get better flexibility. So there's a contrast here between what we are seeing in practice and we're seeing in research, mainly due to the problems of the assessment, the short duration, and also the fact that it's very hard to measure these structural changes. So because this type of stretching is so much used, it's vital that we figure out what's happening with the flexibility training. And then we have gait training. So this is just walking, right? Walking in general. Most studies have been shown to be very safe, feasible, and effective in improving walking ability. There's been no report of serious side effects. And there has been some very good results about structural changes in the triceps surae muscle, which is one of the most affected muscles, using inclined treadmill training. The main problem here is that walking is an automatic and boring motor task. So when you try to change somebody's way of walking, if you give constant feedback, the person starts to pay attention and change a little bit. But after a while, the person already is thinking about what they have to do later in the day or that they are hungry and so on. And the walking regress back to the automatic way that we generally walk. So things like augmented reality are being tested. So you use these goggles that you start walking in a game scenario. So everything is colorful. You have to step in different things to get scores and so on. So that may be a very good option, especially for children. And also there's been some new studies about exoskeletons, which assist the movement, but this is still very new. And we have some colleagues in Helsinki using the exoskeletons, and it's quite challenging because when you start to have the external device helping you to do the movement, the patterns of walking starts to change because your brain already knows that the machine is going to help you. So then you can start walking a little bit different. So it's very tricky, but it's underway. We will have some interesting results about that hopefully soon. So among all the three modalities of training I have shown you, the one that has consistent positive results with no side effects and with the possibility to change motor control, so coordination, joint mechanics, and also increase the aerobic capacity is gait training. So this is very promising. So the aim of our research was to join these three types of training. You're probably aware of that, but in research, usually people try to use just one type of intervention, of training, so that they can assert that the changes that they saw were due to that training type. So this is usually how research is done. But we felt that we needed to address both the three aspects, right? So we needed to work on the muscle weakness, on the incoordination, and also on the flexibility. So the idea was to join the three types of training, and we would lose, obviously, the ability to detect exactly which type of training changed what in the participant, but we felt that that would be closer to a real intervention because it would address different important aspects. So we had 18 participants with spastic cerebral palsy and 17 sex and age matched typically developing controls. The participants had one familiarization session, then a big testing session called pre-1. 3 months later, they had another testing session. So this was the control period just to see how the variables changed with time and maturation, aging, and so on. And then we had the 3 months of intervention, which the participants did strength training, flexibility training, and gait training. And then we stopped the intervention at post-1, waited 3 months, and tested everything again because we were interested in seeing if the adaptations were still be there or if they would have faded away. And the typically developing controls did just 2 main testing sessions so that we could compare with the participants with CP. So first of all, I'm not going to go through the entire intervention because it's very complex. You can find all the details. I'm going to give you this information at the end of the presentation. But basically, we had 2 to 3 sessions of 90 minutes for 12 weeks. We started with gait training, 5 to 10 minutes. This was a warm-up type of activity. And the idea was to have a high quality. So we're not focusing on aerobic training. So if the person was tired, the person could sit down. We're just focusing on doing very good heel strikes and walking the best possible way. The treadmill was mechanical, meaning that the belt didn't move by itself. So the person had actually to perform a hip extension to move the belt. And because it was inclined, it makes the person perform a dorsiflexion at the ankle in a much more pronounced way, which is a muscle that is very weak in cerebral palsy. So the inclined treadmill makes a lot of sense to me. After that, we have 60 to 75 minutes of strength training for the lower limbs and the trunk muscles. The trunk muscles have not been studied at all, to the best of my knowledge, just a few lower limb muscles. It was in total 5 to 7 exercises per session, depending on the participant, how quickly we could adjust everything, and so on. So, for example, here the participant is doing a unilateral knee extension exercise. And after that, we have the flexibility training for 0 to 20 minutes for the diagnosed short muscles. So we didn't perform stretching exercises to participants with normal range of motion. Only the ones that we found in the pre-tests that had lower flexibility, those ones we stretched. So this is one example of the strength test. So this machine moves at a constant velocity, is a isokinetic dynamometer. And with that, we can get the participant is just pushing as hard as possible. So we have this torque curve, and we can get some interesting variables. So the first one is the rate of force development. So how quickly the person is able to raise the torque. This variable is very important for everyday activities because most of the times you do not do your maximum strength. You just have to do like a quick explosion, quick, fast muscle action. There's very good studies showing that increases in explosive strength are well correlated to motor function. Then we have, of course, maximum strength. So the dynamometer is not moving at all, and the person is just pressing as hard as possible, so we can get the maximum value. And then after that, the dynamometer is moving, so it's going up, and the person is trying to press as hard as possible. Oh, sorry. So we can see different variables related to how constant the person is able to keep the torque up. So here you can see that there's some relaxation phases in the contraction. The person is trying to press as hard as possible, but there's always this type of behavior that we call spastic contraction. It's basically the opposite muscle having a burst of activity, which stops the correct muscle from activating. So we did that for shank muscles, for the tibialis anterior, for the triceps surae, for the knee flexors and the knee extensors, and also for the trunk muscles. We had tests for each one of these muscles. After training, walking ability got much better, and also motor function. So participants were able to walk better, to squat better, and climb stairs better, for example. These were the main ones. The muscle strength for the tight muscles and for the trunk muscles got much better. Flexibility for both the hip and the knee joints also got better, about 5 to 6 degrees as a mean. There were no changes for the shank muscles, and there were no changes for the cardiometabolic risk factors, this paper we are publishing right now. So it didn't change any of the risk factors, most that Mark was talking about. So none of this changed. And also there were no side effects to the intervention. And then 3 months later, we have the tight strength and the flexibility. One of the flexibility tests got lower. So 3 months after, the adaptations that we saw from the training, they were already lost. but the walking ability and the knee flexors flexibility was still above the pre-tests. And in this time point, we didn't test the other muscles due to logistic problems. But anyway, the key messages here are that the intervention was feasible, safe, and effective. We only had a few complaints of muscle soreness, but no problem whatsoever with any of the participants. We saw a clear detraining effects 3 months after the intervention. So training must be a lifelong decision. If you want to have more function, to climb stairs better, to walk better, to be able to squat, you will need to do exercise as something that you do every day, every week. It doesn't need to be every day. Maybe perhaps 2 or 3 times a week is already very good. But the point is that you need to think of exercising as something that you just do. It's not something that you need to do because, okay, now my function is decreasing, now I need to do. I think that we need, like Mark was showing, the staircases to the gym. We need to change the framing, and we need to understand that exercise is just needed. It's just something that you need to do. Not so much to think about it. It's just go, and you're going to get used to it, just like you did with brushing your teeth. It's just something that you need to do to have a better life. And of course, I'm not talking only about individuals with CP. This is correct for anybody as well. And another interesting thing is that the intervention was not able to attenuate the cardiometabolic risk factors. And the main reason for that was that the walking was not too intense. So walking was more for a quality purpose because we had a lot of kinematic and kinetic measures. So we wanted to see if walking, paying a lot of attention to the gait itself could change the walking by giving the participant good instructions about how to walk. That's different from just doing a good aerobic training, which the person is going to get a lot of sweat, going to have a lot of elevated heart rate, and so on. So what that means is that strength training alone is not enough. The person also needs to train, to perform aerobic training to get these benefits for the cardiometabolic risk factors. So we still have a lot of data to publish. We are studying the spastic core contraction before and after the training. We're also having many measures about hyperreflexia, hyperresistance. These are all papers that are currently being worked on. So we have a very comprehensive amount of data that we want to check and see how the intervention changed them. But the main thing is that we have the protocol paper published with all the details about how to implement the intervention. We have a YouTube channel which explains exactly how to perform each one of the exercises. At our website, we have also a lot of information about how to execute this. And the main purpose of this talk is just to show that training really works. It doesn't have any important side effects that you need to be worried on. And it's very feasible. If you enter in the YouTube channel and check these resources, you will see that it's something that you can do perhaps with your parents or by yourself, and you can ask somebody else for help in a few exercises. So it's something that you can start Monday, right? So that's my wish, that you understand that training is good, and it's something that is upon you to start as well. So, and we also have this last link, everything that has to do with research, we publish there. So all the raw data, obviously anonymized, all the analysis scripts, everything. So we try to be fully transparent and show everything that we're doing so that people can trust that the results are indeed very good. But that's it. This is my email. If you have any questions later, you feel free to contact me as well. Thank you very much.
Thank you very much for this both interesting but also kind of practical presentation. I mean, strength training or training is for everyone. Really for everyone, and you know, to train at least a few times a week is really something that all of us has to think about.
Yes.
Thank you very much, and we will come back to questions afterwards, after this last the presentation. Thank you very much.
You're welcome.
For this. Now, our next presenters are an excellent example of interprofessional work. I have the honor to presenting Sevérine Hedberg, who is a psychologist, Ellinor Nilsson, who is a physiotherapist, and not here, but part of the team, Louise Lunde, who is an occupational therapist. And you all work at the habilitation in Östergötland in Sweden. And you have studied how adults with CP experienced a six-week fatigue management course. And will in your presentation both hopefully present the course and what the course was about, but also what your studies resulted in. So please,
yeah, that's right.
exciting presentation coming up. The floor is yours.
Thank you, and thank you so much for inviting us. I will try to share my screen then.
Yes, now we can see it very well. Thank you.
Perfect. Yeah, so as you said, we're here to present our work on fatigue in adults with cerebral palsy, and mainly the management of fatigue that we have been working on for some time here. And as you said, we're from Östergötland in Sweden, which is in the southeast part of Sweden, for those who don't know. And we work here in a town called Linköping. And yeah, as you said, I'm Ellinor then, I'm a physiotherapist, and you will hear from Sevérine later, who's a psychologist. And also we work with an occupational therapist, Louise. So what are we doing and why are we doing it? Well, we have been looking into fatigue management through courses for adults with cerebral palsy. And the reason that we started this work at our clinic was that we met a lot of patients here that experienced fatigue, and we realized that there was little or nothing in the literature that told us how to support them in the best way. And yeah, we read about how fatigue associated with other chronic conditions, such as multiple sclerosis, had been managed, and we encountered the 6-week course, Managing Fatigue by Packer. And initially it was, I think it was actually 2020 during COVID, we started to conduct this small study at our clinic using this existing course, and we will tell you a bit of about that today. But also based on that experience, we modified the course to try to meet the needs of people with cerebral palsy even better. And at the moment, this new course that we call Why Am I So Tired? Understanding and Managing Fatigue for Individuals with Cerebral Palsy is being tested at several habilitation centers here in Sweden. And we will tell you about this course and the ongoing study. But to start with, what is fatigue? One way to describe it is made by Casa several years ago as a reduced ability to maintain force or power output, reduced ability to multitask over time, and simply a subjective experience of feeling exhausted, tired, weak, or lacking energy. And fatigue is a symptom that is commonly associated with various chronic conditions and injuries, including cerebral palsy. It's a persistent and burdensome feeling of tiredness that is hard to recover from. And it can be experienced differently from person to person and depending on the situation. Often it is divided into mental or cognitive fatigue and physical fatigue, where mental fatigue can manifest as difficulties in concentrating, remembering, or feeling overwhelmed by activities and stimuli. It may also affect one's ability to process information and stay engaged, leading to a sense of mental exhaustion even after minimal effort. And social interaction, which requires focus and emotional energy, can be particularly draining, contributing to a deeper sense of fatigue. And this mental strain can influence your mood, potentially causing feelings of sadness, frustration, or irritation. Physical fatigue, on the other hand, is often experienced as a sensation of tense or sore or weak muscles, making even simple tasks feel more demanding. And also this physical exhaustion may also amplify mental fatigue, creating a cycle between the body and mind, that they're both struggle to recover. Yeah, and fatigue in people with cerebral palsy. In adults with cerebral palsy, fatigue is one of the most common health problems, especially for those with moderate to severe physical impairments. And almost 50% reports fatigue. And it's associated with perceived poor health. And you often see a combination of fatigue, pain, and depression or mental health issues. It seems clear that people with cerebral palsy experiences both physical and or cognitive or mental fatigue, but especially the mental or cognitive fatigue part are still poorly understood in this population. And the most common factors contributing to CP-related fatigue were studied in a study from Canada. And they were activity-related factors and general demands of life and poor sleep or rest, which all are potentially modifiable factors, of course, meaning that if we can do changes here, it would affect the experience of fatigue in some way. Despite fatigue being a significant concern in this population, the understanding of the underlying factors remain limited. And this complicates the measurement and the assessment of fatigue in individuals with cerebral palsy. And more research is, of course, needed to understand fatigue better, but also to explore interventions and educations in managing fatigue. We also want to note this, that even though it is common with fatigue in people with cerebral palsy, there is an importance to undergo a medical examination by a physician to rule out other potential medical causes of fatigue or tiredness.
Yes, thank you, Ellinor. So back to our work in managing fatigue for people with CP. The original Parker's course called Managing Fatigue has been translated to Swedish by occupational therapists and used as the ground of our study. That's the title that you see here, Fatigue Management. It's the Swedish translation. It provides knowledge about fatigue and increase the ability to manage everyday activity and focus on the importance of rest, the use of strategies, techniques, tools, as well as ergonomics to achieve occupational balance. The course is based on group interventions with focus on occupational balance. The aim of our first study was to explore experience of the managing fatigue course and adapt it to CP. We knew from the beginning that the course was modifiable, and then we thought that it will be great to adapt it to CP. The first study, it's a very small scale qualitative study based on the interviews of 8 adults with CP who attended the course. The course spans over 6 weeks with 2 hours sessions per week. Between sessions, participants are assigned homework related to the topics covered in the different sessions. This first study was published last year. And what did we learn? Yeah, here you can see the result of our study presented in main categories and subcategories. The participants in the study found that the course was challenging and eye-opening, and it was also giving the participants deeper self-understanding and thought about making changes. They describe an increased awareness and knowledge regarding fatigue. For many of them, it was a new knowledge, and an insight regarding the opportunity for the change. However, it emerged that the course was not perceived as sufficient to implement the new knowledge in the everyday life, and the need for additional individual support was raised, as well as the desire of more discussion on fatigue and its relation to CP. Well, yes, nevertheless, the result provided promising outcomes regarding the applicability of a fatigue course for people with CP, and offered a base for further development of intervention. It came clear to us that modifications were needed to optimize the intervention. And well, we thought then that it was important to target more on the individual and individualized information, and well, additionally, it was also important to extend the duration of the course, introduce individual support with follow-up session, and the participants also wanted more focus on the relation between fatigue and CP, as said earlier. Finally, we also saw the need of a multi-professional team to lead the course. So we have been working with this modification, and we hand it up with a new course called Why I Am So Tired, Understanding or Managing Fatigue for Individuals with CP. The course Why I'm So Tired is about gaining knowledge and deeper understanding of fatigue in the context of CP, providing an opportunity to find, use, and implement tools, as well as providing strategy for achieving better balance in daily life and managing fatigue more effectively. Similar to the Managing Fatigue course, this new course is based on occupational therapy group, intervention, focus on activities balance, and it's combined with a structured, inspired by behavioral changes therapy. In the new course, the physical and bodily challenges associated with the condition are strongly emphasized, without neglecting mental fatigue. Well, knowing that fatigue often coexists with pain and mental illness, it was important to us that the new course was including the involvement of multiple professionals for a more comprehensive approach, and therefore we decided to involve both occupational therapists, psychologists, or social care workers, as well as physiotherapists. Yeah. The new course, how does it look like? Well, the course spans over 11 weeks with 7 on-site sessions and 2 individuals follow-ups. The first sessions is 2 hours, and all the other are 1.5. There is a coffee break in the middle of the sessions. All sessions included lecture, group discussions, active work in groups individually with different assignments connected to the session's topic. Every session included relaxation exercise. The first 3 sessions that you see on the screen is about increasing understanding and awareness of fatigue and its connection to CP. How is fatigue experienced? What do participants feel? Focus is also on the importance of the rest and recovery to explore the consequence of fatigue, as well as how it affects daily life. Other targets is to discuss what importance for well-being, the concept of occupational balance, and reflect on what participants do or has to do now versus what they would like to do. The third session is led by a physiotherapy. We focus on how the body functions, how with CP, including pain, spasticity, and how physical activity affects fatigue. We also explore ergonomic strategies and the use of assistive device to reduce strain. The third sessions is the first of 3, where we focus specifically on activities balance. In short, we start by getting an overview of what a normal day looks like. Then we look at how it looks and how it could be modified, and how to create new, more sustainable habits in daily life. As you see, there is 2 individuals follow-up that we do remotely, where we provide personalized support for the assessment and overall progress. We also discuss challenges, well-being, and potential additional support needs. In the second follow-up, we also encourage family involvement for some home support. Under the final sessions, yes, the goal is to ensure participants live with tools and strategies, knowing what works for them personally, so they can continue making progress independently.
Yes, so we are now currently conducting a study on this course, which aims to explore the feasibility of the course, Why Am I So Tired, for individuals with CP, and also to pilot test how attending this course affects the self-reported experience of fatigue and occupational balance in daily life. At the moment, the course is being held at 5 different habilitation centers here in Sweden. And our plan is to assess with surveys on the participants' experiences from the course. And we also ask the course leaders to write logbooks with their experiences. We also do measurements of self-reported experience of fatigue and occupational balance, of course. We do it before the course. We have done it before the course started. We'll do it afterwards and at 3 months follow-up. To be included in this study, the participants need to be adults, have cerebral palsy, of course, and experience fatigue, as measured on the fatigue severity scale or on the modified mental fatigue scale. And we will come back to these scales later. We decided to exclude patients with intellectual disability because this course has not been developed with that target group in mind. And we also exclude patients that have other medical cause of fatigue, that have mental illness or sleep disturbance that requires other treatment at the moment. Yeah, so we will just give you like a picture of the participants that we have in our study. We have 34 participants with a mean age of 43, but it's a big span. I think the youngest is 21 and the oldest 77. The green part in this circle, it's for females, so about 2/3 of the participants are female, are women. And regarding the subtypes of cerebral palsy that are represented in our sample, there's a majority having spastic cerebral palsy, but that also reflects the general distribution of subtypes within CP. Interestingly, about 1/5 are unaware of which subtype of CP they have. And then if we look at the GMFCS levels in this sample, there are participants from all levels, but with the majority in levels 1, 2, and 3. Yeah, and we want to show you some numbers from the pre-measurements for fatigue and occupational balance, just to give you a like information on what we will look at afterwards as well. Yeah, we have chosen to use several different fatigue assessments to try to capture all possible aspects of the individual's experience of fatigue. Currently, to the best of our knowledge, there is no like fully validated assessment scale in Swedish, such as the FISA that some of you may have heard of. It has not been translated to Swedish yet, but hopefully it will be. All of these three are self-reported questionnaires used to assess the impact of fatigue of a person's daily life and activities. And the first one, the fatigue severity scale, is something that we use in Sweden in CP-UP. That's like the big CP register that we have. And it consists of 9 statements related to how fatigue affects motivation, physical activity, and social functioning. And you rate each statement from 1 to 7 with higher scores indicating more severe fatigue. And the results on FSS are often calculated as a mean, and this total score can be between 1 and 7, and a mean of 4 and higher often indicates fatigue. And the mean value in our sample is 5.65, but of course with some variation. And then we have the modified mental fatigue scale, which is based on the mental fatigue scale, and is a self-assessment tool developed to evaluate mental fatigue. And this scale was modified a couple of years ago here in Sweden to meet people with cerebral palsy better. And there is a proposed cutoff in the scale of 10.5 or over, and the participants in our study have a median of 18, but as you can see, it's a wide range. And lastly, we have the multidimensional fatigue inventory. It's designed to assess fatigue a bit broader across 5 different dimensions. And if we look at the 3 of these dimensions, general fatigue, physical fatigue, and mental fatigue, this is the score for the participants in this study that we will use later as well. And closer to 20 means more fatigue. Yeah. And since the core of the course focuses on occupational balance, we have also chosen to evaluate using the OBQ11, the Occupational Balance Questionnaire. And this questionnaire was developed to measure the individual's perception of their own occupational balance. And the highest total score, the more occupational balance you have, where 33 is the highest score. And as you can see, the participants in our study are spread over the whole scale here, but with a median of 12. And as we discussed earlier, we know that there is a connection between pain, mental health issues, and fatigue. And that's something that we also see in this sample, with a huge majority reporting some kind of pain. But of course, as we heard earlier from Professor Peterson, this is something that we see in people with CP in general, but I think that this number, even though it's a small sample, is a bit higher than what has been reported generally. And this is just that they reported some kind of pain, like yes or no. And also when we look at mental health issues through the hospital anxiety and depression scale, where a score of 8 or over could indicate mental health issues, we see, especially on the anxiety session, a large group in the sample that reports some level of anxiety, and 1/4 reports some level of depression. Yeah, and as I mentioned, we just collected these pre-data, and we haven't yet had time to interpret them any further, but it will be, of course, interesting to analyze how these assessments are associated within one individual. And yeah, we will use the same assessment after the course and at 3 months follow-up to see whether they change in any ways after completing the course and how stable such a change is. But we don't have any controls for this, just like a pilot test. Yeah, and our plan is that we will have this collected by April next year. And yeah, thereafter we will, of course, try to publish it, but also like spread it in different ways. And with the combined assessments, we can further develop the intervention. So in summary, it is evident that fatigue is a widespread health issue among people with cerebral palsy, and much more work is needed to understand this phenomenon, as well as to find methods to address and manage CP-related fatigue. And we think that if this course turns out to be a good way to do that, we see great potential of further developing it and modify it in other ways. For example, adapting it for people with intellectual disabilities. We will, of course, try to have it online and so on. Yeah, so yeah, that was all from us. Thank you all for listening, and yeah, please ask us questions in the chat or contact us later. Here's our email addresses, and yeah, also we want to send a big thanks to all the course leaders giving this course at the moment, and of course also to all of the participants. Thanks.